let's transition now from the standards of therapy that we've been talking about, multidisciplinary care, cytotoxic chemotherapy, EGFR inhibition, and some of the emerging data around especially immunotherapy in head and neck cancer. Let's first set the stage, Viktor, if you don't mind. What's the unmet need for patients with head and neck cancer?
So the question would be, for what part of the population do we talk about? And I think, as has been kind of a theme among this discussion that we have, is that we have different populations. And HPV-positive disease have a complete different requirement than HPV-negative tumors. And for HPV-positive, and we have a high amount of patients that do survive. So long-term survivorship is really already in place for these patients. So whatever we do for localized disease, for definite treatment, it will have those patients live long enough to face their late-term toxicity. So de-escalation certainly is the goal for these patients. And for those that are HPV negative, the high amount of tobacco smokers, for those we have long-term outcome, which I'm not satisfied with. It's not enough what we deliver here with our treatment. We certainly have to improve. Maybe it is a more intensified treatment approach in these patients. Yeah, that's something Tanguy referred to as well. So is new induction therapy, is that the way to go for? So, and I think there are many ways to envision the data, and it's not quite clear and very controversial how to really approach this.
And so I'm hearing you say for a group of patients with good prognosis, HPV positives, you're thinking about how to reduce the long-term toxicity and maintain cure. For a group of patients with a worse prognosis, let's say HPV negative, how can we improve cure rates? Because we're not satisfied. Let's move from the locally advanced setting to the recurrent metastatic. What are the unmet needs there?
I think there it's much more prevalent because overall survival is very unsatisfying. We have evolved from single agent cisplatin to a trimodality treatment using 5-FU cisplatin EGFR inhibition, and still, you know, we're in the range of 1 year of overall survival. So this is really an outlier in terms of our overall cancer perspective, what we see in other diseases. So it's about time to move along with head and neck cancer in the relapsed and metastatic setting to improve outcome. And so certainly survival is a key issue that we must succeed if you would like to improve outcome in these patients.
Yeah, I mean, when you think about it, prior to this year, there was one drug approved in head and neck cancer in the last 20 years, which I think you're right. I think we've fallen short of the advances that other malignancies have seen. Having said that, Tanguy, what is your approach to treating patients with recurrent and metastatic disease, and focus, if you don't mind, especially on the platinum refractory patients?
Yeah, so I think when a patient fails curative intent therapy, so has recurrence, or if somebody presents up front with metastatic disease, the treatment goals change. I think if somebody has a localized tumor, we will try to re-resect or to resect the tumor if feasible. And sometimes we'll also try re-radiation, which I think is, for some patients, feasible, but very toxic approach that only few patients can do. So as soon as that's no longer an option, then we talk about palliation. And as was mentioned, the life expectancy on average is about a year. And really, our treatments are not very good. So if we have patients who have not been refractory to platinum, we would use the extreme regimen, or at least doublet chemotherapy, so plus minus cetuximab. Most of the time, that's platinum plus 5-FU, and then you can add on the cetuximab. In the United States, a lot of us like to actually replace the 5-FU for the side effects and the inconvenience with a taxane. And there is some data emerging, and I think it's not unreasonable, but the data actually goes for 5-FU. In patients who fail within 6 months, so the platinum refractory patients, and that definition is a little bit arbitrary, but by and large, we would say those patients are the ones that should go on to single modality treatment. So in the past, up until a few weeks ago, the recommendation in the United States would have been for a taxane, for methotrexate, or for cetuximab, single agent. However, recently we saw very exciting data on multiple studies that that patient population may actually have great benefit from immunotherapy, and I think we all were involved in this. And so on August the 5th in the United States, we actually saw approval of the first immunotherapy, that being pembrolizumab, a PD-1 inhibitor, for patients who are platinum refractory. We likely will see approval of a second agent also very soon, but I think it's exciting. You know, as you mentioned, for 20 years, we've had a single drug approved, that is cetuximab, and a lot of discussion has been had about how effective it is, but now we have an agent that really changes the paradigm. That's a new class of treatment, and we actually are seeing some amazing benefit in some patients, in a subgroup of patients where we see long-term benefit, something that I think we've never seen before.